السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم، والصلاة والسلام على خير الأنام سيدنا محمد وعلى آله وصحبه وسلم. Welcome back. New lecture of pharmacology. Today we'll discuss the therapeutic guide to hypertension management in special consideration in comorbidities and how to follow the patient with hypertension. Also, we will discuss the resistant hypertension management. So, firstly, we start by the comorbidity associated with the hypertension, how we can manage the patient who has a hypertension with one of these comorbidity. Firstly, if the patient has a history of stroke or transient ischemic attack, we can use any of the first line treatment uh, except the calcium channel blockers. So we use thiazide, ACE inhibitors, or ARBs in this patient monotherapy or as a combination. The combination could be more beneficial for the patient if has a stroke. And the target should be below the 130 and 80 by using the drug. And if the patient has a stable ischemic heart disease, atherosclerosis heart disease, if the patient is develop angina or not, so the initial therapy will be the most important here. We have to use the beta blockers and also the ACE inhibitors and or EARBs. So we can use for the patient ACE inhibitors with a beta blockers or ARBs with a beta blockers. If the blood pressure is controlled, it's okay. If not, so we can add drugs like calcium channel blockers, dihydropyridines like amlodipine and these drugs if the patient has angina. If the patient has not, we can use it again, and we can use thiazide or aldosterone antagonist besides these drugs. زي ما قلنا the most important the beta blockers and ACE inhibitors or ARBs, and then we can add it the calcium channel blockers, dihydropyridines depend on the patient need, and the goal also is below 130 and 80. In chronic kidney disease, here we have a different recommendation, slightly different, with difference between the heart committee and chronic committee. Here we discuss depend on the kidney committee guidelines. And the blood pressure targets here should be below 120 if we can, and if tolerated. If not, so not more than 140 for the patient. The medication, the main medication should be used or could be used in patient with a hypertension and chronic kidney disease is ACE inhibitors and ARBs because they cause a neuroprotective effect and they are reduce the proteinuria for the patient. Uh, if got any patient with a diabetes, which commonly also associated with a chronic kidney disease, diabetes, hypertension, and chronic kidney disease, this drug is preferable for this patient, especially if the patient has a proteinuria. But here we have to make attention, this drug can decrease the renal function. So we have to do a renal function test for the patient before, and we have to monitor the renal function test for the patient. If the patient has symptomatic hypotension after using the drug or uncontrolled hyperkalemia, because the drug can cause a hyperkalemia, a high potassium level, or the GFR of the patient or renal function. Creatinine for the patient is decreased uh, more than 30, so we have to adjust the dose or even stop the drug. If not, so we can continue the drug. We can check the patient within 2 weeks and then within 4 weeks, and we make a decision after 4 weeks if the patient زي ما قلنا has one of these indication, we can stop or adjust the dose for the patient. Otherwise, we continue in the dose that controls the blood pressure for the patient, and we continue with this drug. Very good drug, لكن associated with decreased renal function in some patients. طيب. If the patient is uncontrolled, in spite uncontrolled hypertension in spite of using of the drug, so we can use or adding a calcium channel blocker, thiazide diuretics or loop diuretics. طبعا thiazide diuretics the GFR should be high, more than 30 and even more than 60, preferable يعني, and loop diuretics could be used even with a low GFR. Like for resistant cases, we can adding more drugs like aldosterone and beta blockers. Like in the most important one, well, ACE inhibitors and ARBs or RAS inhibitors. طبعا we don't like to use all RAS together because it can cause, which is called as a RAS blockade, which can lead to severe hyperkalemia for the patient and acute kidney disease or impairment. If we use ACE inhibitors, ARBs, renin inhibitors, screen together. طيب non drug management for this patient طبعا بنعمل لهم lifestyle change اللي هم looks like the lifestyle which is used in hypertension اللي هو weight loss or exercise وال diet of the patient. طيب if the patient has a hypertension and diabetes, commonly we use ACE inhibitors and ARBs, especially if the patient has albuminuria or has a proteinuria. If not, is a patient عنده albuminuria, so we can use any of the Paris line. وبالتالي ممكن نستخدم ACE inhibitors, ARBs أو calcium channel blockers أو thiazide diuretics. And the target should be below 130 and 80. Like, what if the patient has a hypertension with a congestive heart failure? We have two types of heart failure. As a classification, we have a heart failure with reduced ejection fraction, and we have a heart failure with preserved ejection fraction. Ejection fraction يعني we regard the patient with preserve and normal if it is more than 50%. So 50% the ejection fraction is a preserved ejection fraction, and if it is below 40, it could regard as a reduced ejection fraction. So, if we have a patient with a hypertension with ejection fraction below the 40, we have to use beta blockers for this patient for control of the patient. Besides other drugs like first line treatment اللي هم ال ACE inhibitors, ال ARBs, and even we can use the diuretics طبعا depend on patient status. Like in this patient with reduced ejection fraction, we avoid use of non-dihydrocalcium channel blockers, which is affecting the blood vessels and cause a vasodilation. It can aggravate the case, so we don't use the dihydropyridines, calcium channel, non-dihydropyridines, calcium channel blocker, sorry, اللي هم ديل affecting the heart mainly, اللي هم decrease the heart rate and decrease the contractility, so acute it can cause يعني progression of the reduced ejection fraction and can lead to heart failure or acute heart failure for this patient. يبقى the summary, if the patient has a heart failure with reduced ejection fraction, we use a beta blockers and others. We can use a beta blockers and ACE inhibitors or ARBs like the patient with ischemic heart disease, and also here we can use a diuretics and a patient with a reduced ejection fraction, likely the patient has a fluid overload symptoms for the patient اللي هو ممكن يكون حاصل له edema, peripheral edema like that. If يعني it is right side or if it is a left side, it could be associated with pulmonary edema وكده. وبالتالي we have to use the beta blockers and ACE inhibitors in reduce and avoid the calcium channel blockers, the elfirapamil and deltiazem. If it is preserved ejection fraction, the ejection fraction is above 50, so we can use the diuretics if the patient has fluid overload، اللي هو البيشنت بيكون عندهم edema زي ما قلنا وكده. we can use the diuretics to decrease the edema and to relieve the heart, and we use the beta blockers and ACE inhibitors when the patient has no overload. Could be used also with a combination together, the drugs together. And we avoid the nitrates in this patient. And nitrates is a potent vasodilator, and it decreases the return of the blood to the heart, which could affecting the patient. The target is like the other target is 130 over 80 for most of patients. If the patient is asthmatic, in asthma, the preferred drugs is ARBs, calcium channel blockers, and thiazides. Like we avoid the beta blockers, and beta blockers, it can block the beta 2 receptors, which can cause a bronchoconstriction. So if mandatory to use, we have to use a cardio-selective beta blocker. So we use a drugs which is just block the beta 1, because the drugs which is block both beta 1 and 2, it could cause a bronchoconstriction. In general, we try to avoid the beta blocker in general, like we can use a selective if mandatory to use. If the patient has osteoporosis, we need a drug that increase the calcium. So the preferable drugs is thiazide diuretics, which is reduce the excretion of calcium and then increase the calcium in blood. In gout, we have to use a drug which doesn't increase uric acid, and that is why we avoid the thiazide diuretics, and we prefer to use a drug which decrease the uric acid, and this is commonly used the ARBs, which is better even than ACE inhibitors in uric acid. It decreases the uric acid. We use the losartan, which has a uricosuric effect. ACE inhibitors and calcium channel blockers could be used without effect on uric acid. In migraine, we use a drug which treats the blood pressure and in the same time could use as a prophylaxis for migraine. We use the beta blockers and calcium channel blockers. This is summary and a tables for the treatment based on medication comorbidities. As we see here, we have the comorbidity and the initial therapy, what we can add, and the goal of blood pressure and the special consideration. So it is a summary for who like to read from the table. It's a summary and it's a simple way to summarize all the lecture about the comorbidity. For the follow-up of the patient, if the patient is on treatment, for example, and coming for your clinic to follow up, what we have to follow. The goal is to evaluate the medication adherence, and if the treatment is effective, and if we need to do a lab study, we do, and we have to adjust medication to control the blood pressure. يبقى the goals is to check the medication adherence, and the treatment effectiveness is the patient is controlled or not, and to adjust the medication. Fine. When we have to follow the patient, if the patient in non-treatment, in non-pharmacological therapy, so we need to see the patient every 3 to 6 months. If the patient is in new medication, we add or we adjust the dose for the patient. We have to see the patient every 1 month until the patient is controlled. And then if the patient is controlled blood pressure, so we can see the patient every 3 to 6 months, and then annually we can see the patient. طيب. The laboratory monitoring, the most important lab study should be done is electrolyte and creatinine for the patient, especially لأنه most of the drug is affecting the electrolyte, especially the ACE inhibitors and ARBs associated with زي ما قلنا affecting the creatinine and associated with impaired renal function in various days or various weeks اللي هو up to 1 month. So we have to check the patient for hyperkalemia, for example, and creatinine in this phase. طيب. We have to do a medication adjustment, and we have to treat the electrolyte disturbance if the patient has one of them. If the patient has a hyponatremia, decrease in sodium, we can, which is commonly associated with the thiazide, we can stop the thiazide or adjust the dose, and we can use instead the loop diuretics. And if the patient has a hypokalemia, we can use or add a potassium sparing diuretics. لكن most likely if the patient has a hypokalemia طبعا highly associated with thiazide, diuretics use. Before we use a potassium sparing diuretics, we have to check the patient for hyper aldosteronism also, which could associated with hypokalemia وكده. So we do a search or investigation for about the hyperaldosteronism. Then we can add a potassium sparing diuretics, also ACE inhibitors and ARBs could treating the hypokalemia, we can add them. If the patient has a hyperkalemia, we have to adjust the dose of drugs associated with hyperkalemia هم ال ACE inhibitors wal ARBs wal potassium sparing diuretics. So we have to adjust the dose, and if it is not controlled, we can add thiazide, which cause a hypokalemia, so can adjust the potassium level. ACE inhibitors induce cough if the patient develop a persistent dry cough with ACE inhibitors. We can switch from ACE inhibitors to ARBs, which doesn't cause cough. And then we can do escalating strategy. We can increase the dose to control the blood pressure. We can increase the dose, and we can switch drug classes اللي هي sequential monotherapy. So we change from a drug to other drugs if develop a severe adverse effect, for example, and add a second drugs to control the blood pressure. And if still the blood pressure is high, we can use a third drug, and this is if it's not controlled after that, called as a resistant hypertension. Like, what is resistant hypertension? Resistant hypertension is using of 3 drugs, antihypertensive drugs. One of them is thiazide, and still the patient is uncontrolled blood pressure above the target blood pressure. And this is could affecting 15% of the patient. If we have a patient with a resistant hypertension, firstly, we have to rule out the pseudo-resistance. Pseudo-resistance means the patient has no resistance, like in there is a factor that cause a resistance for the patient, like inaccurate blood pressure measurement or poor medication adherence of the patient, or the patient has a wide coat hypertension. Then second, we have to optimize the non-pharmacological factor. We have to advise the patient about the lifestyle, medication, and to reduce or stop the drugs which is increase the blood pressure زي ما قلنا زي anti depressive drugs which is used by the patient if the patient using a cocaine or amphetamines أو منشطات وكده. طيب. Then we have to screen for the secondary hypertension. And if there is a cause for secondary hypertension which is controllable or treatable, we have to treat the underlying cause. Then we do medication optimization, not directly adding a drug or adjust the dose for the patient we have. to do all these process before we change the dose or drugs for the patient. طيب. Firstly, we have to ensure زي ما قلنا in persistent hypertension إنه the thiazide is one of drug which is used. طيب. The first drug, first line use in most of patients with resistant hypertension is a potassium sparing diuretics. We use aldosterone antagonist, the spironolactone or amiodarone. And we can depend on patient and patient status. We can use other drugs to control, of course, drugs to control the patient status. We have a beta blockers and we have a loop diuretics and a direct vasodilator. If the patient is persist for the treatment and continue as uncontrolled hypertension, we need to refer to specialist, or if we suspected a secondary hypertension, we have also to refer to a specialist. For example, if the patient has a chronic kidney failure, we have to refer the patient for a nephrologist and like that. And other drugs also or other disease, we have to refer to specialist. Like this is the last slides. We speak about the special population when we use this drug and what the drug is preferable in some patient. We prefer to use in black patient without a chronic heart disease or kidney disease. We prefer to use a thiazide, diuretics, or calcium channel blockers. So if we have a black elderly patient without chronic kidney disease, without heart failure, we can use a calcium channel blockers as a main drug for treatment of the patient and the first line treatment. If the patient has a chronic kidney failure, especially if the patient has a proteinuria, the ACE inhibitors and ARBs is preferable. طبعا if not, we can use other first line treatment. If the patient has diabetes, well, the patient has no albuminuria, we can use any of the first line. If the patient has a proteinuria with diabetes, we prefer ACE inhibitors and ARBs. If the patient has a heart failure or post-myocardial infarction, we prefer beta blockers and ACE inhibitors, and we discuss the details when the patient has reduced ejection fraction. We prefer the beta blockers at the first line with ACE inhibitors. If the patient has a preserved ejection fraction, we use diuretics if there is a fluid overload. If not, we use the beta blockers and ACE inhibitors. If the patient has atrial fibrillation, we can use something control the fibrillation and can control the rhythm. So we can use a beta blockers and we use a calcium channel blockers which is affecting the heart here non-dihydropyridines. Here is very important to know the drugs which is used in pregnancy. In pregnancy, we don't use any drug because the teratogenic effect of the drugs. So the preferred drugs to use during pregnancy زي ما عارفين عندنا حاجة اسمها hypertension in pregnancy induced hypertension PIH. If the female develop a hypertension during pregnancy, all the female with a hypertension and then get pregnant, we have a four main drugs used, which is hydrolazine, methyl dopa, nifedipine, and labetalol. This is drugs is safe during pregnancy and it has a mnemonic. You can take the first letter of each word. In hypertensive, moms need love. H for hypertensive اللي هي hydrolazine. Mom M is methyl dopa. N needs is nifedipine, and love L is labetalol. So hypertensive mom need love. And if the patient has isolated hypertension. زي ما قلنا also we prefer, especially in elderly, we prefer calcium channel blockers or thiazide. For the safety consideration, all of them are discussed before. This is just to memorize that we have to monitor the adverse effect commonly associated with each drug. The thiazide diuretics is associated with hypokalemia and hyperglycemia, and calcium channel blockers, especially verapamil, associated with edema and constipation, and the ACE inhibitors associated with hyperkalemia, with angioedema and cough, and patient adherence. We have to simplify the regimen and good education for the patient about the use of the drug and and side effect of the drug. That's all, and thank you very much. See you later.